Great, thanks Frederick, and thanks everybody for attending. So in type 2 diabetes, obviously patients with diabetic kidney disease, we're focusing on blood pressure control, glucose lowering, reduction of proteinuria. A lot of these patients will use blocking agents of the renin-angiotensin system, RAS blocking agents. But despite that fact that they use RAS blocking agents, there's still an unmet need to treat diabetic kidney disease. We know that SGLT2 inhibitors such as dapagliflozin decrease A1C levels, but they also reduce body weight, blood pressure and albuminuria. A big question is how they interact with each other. We know that SGLT2 inhibitors can reduce pressure on the glomeruli by increasing resistance in the efferent arteriole, whereas we know that RAS blocking agents will induce vasodilation of the efferent arteriole. And one question that pops up is whether the efficacy of dapagliflozin is similar in patients with or without these RAS blocking agent use, and also a safety issue if you use two inhibitors or have agents with two renal hemodynamic effects, whether this predisposes to potential renal events, adverse events. So we investigated this with dapagliflozin in patients with type 2 diabetes with or without a RAS blocking agents, but with albuminuria at baseline. It was a post hoc analysis from 13 placebo-controlled phase 2 or phase 3 trials, so they were relatively of short duration, 24 weeks at most, and we assessed whether there were differences in these groups. We included 957 patients with a RAS blocking agent and 302 without a RAS blocking agent, and their characteristics are named in table 1. They were fairly similar, but as can be expected that the patient that did not have a RAS blocking agent at baseline were a little bit more healthier. They had shorter duration of diabetes, 6 versus 11 years. They were a little bit leaner and they had lower uric acid, but in other terms they were pretty comparable. So what we looked and we compared the effect placebo adjusted of dapagliflozin on these cardiovascular and renal risk factors. And as you can appreciate is that the effects of dapagliflozin on urinary albumin, creatinine ratio excretion, on eGFR, the slope of the eGFR, A1C reduction, and an increase in hematocrit, which is a marker for the volume contraction, were exactly similar between the groups. There was a small difference in body weight and in uric acid, where people that had no RAS blocking agent at baseline had a little bit greater decline, and blood pressures were fairly similar. When you pool the entire group, so this is a graph containing both the people with or without a RAS blocking agent, the use of a RAS blocking agent was not a big predictor in the response of UACR decline. And finally, when you look at safety, in particular the renal safety, there were no more renal adverse events in the combined group versus the group that used SGLT2 dapagliflozin without the RAS blocking agent. So I think that this analysis shows, with the limitation of the short duration of the studies, that on the one hand the efficacy of dapagliflozin is preserved in patients that use a RAS blocking agent. It's not surprising because of the different mechanism of action, the different renal mechanism. And on the other hand, two renal hemodynamic drugs are still safe in terms of combining an SGLT2 inhibitor with a RAS blocking agent. And this is also what we see from the larger trials, the CVOTs that have been done.